Honorable Chairperson, respected panel of expert, learned audience, good afternoon. I am going to present my case, that is double trouble, hurdle to reach the destination. Mrs. X, 35 years old lady with a history of CRTP implantation, 6 months back, came to our emergency department with the complaints of shortness of breath, NYHA class 2 or 3, tiredness and palpitation. CRTP was implanted due to non-ischemic dilated cardiomyopathy with the ejection fraction of 28%. On query, she gave history of LV lead dislodgement on third period of her CRTP implantation. She gave no history of vomiting or extraneous activity or any illness between this period. This was her admission ECG that showing the QRS complexes are wide with only the RV pacing and LV pacing is missing. So in the view of dislodgement of her history, so we integrated the device, and on XHS it showed that LV lead is displaced and it is looped in the right atrium from the coronary sinus. Her routine investigation was done and it was quite okay. With the echo was directed LV with severe global LV systolic dysfunction with LV ejection fraction 28%. This was her first ECG during before the CRTP implantation, that is showing the white QRS complexes with LVBB morphology, and that was her last ECG during the discharge with narrow QRS complex with biventricular pacing. So fluoroscopy was done, and that shows that the LV lead is dislodged into the right atrium and looped into the right atrium. So we planned for the re-implantation of the repositioning of the LV lead. So LV lead was removed, and we tried to put an CS sheath to cannulate the coronary sinus. We used a floppy wire to cannulate the coronary sinus, but we failed after several attempts. Then we took the help of a CS catheter to cannulate the coronary sinus, and with the help of a CS catheter we cannulated the coronary sinus, and coronary sinogram was done. And through the coronary sinus sheath we passed a floppy wire into the middle cardiac vein, and in the support of the floppy wire we implanted the LV lead into the middle cardiac vein. As there is a discrepancy between the lead diameter and the venous diameter, we decided to fix the lead into the venous system by means of an stent. So we inserted another floppy wire, that is the run-through wire, beside the LV lead, and implanted a drug-eluting stent (4 into 12 millimeter), deployed at 8 atmospheric pressure, and followed by high inflation was done at 16 atmospheric pressure, and LV lead was fixed within the venous system. And after a gentle traction, it was confirmed that the lead is being fixed within the CS. And this is the final picture showing that LV lead is being fixed and the stent in situ in the proximal part of the LV lead. And this is the ECG just after repositioning of the CRTP, that is showing the narrow QRS complex with biventricular pacing. And this is the ECG on after first month of follow-up. So in spite of improvement in lead design and delivery system, high incidence of lead dislocation is observed. It is between 2 to 12%. The use of coronary stent technique has been proposed as an alternative method for stabilization of the LV lead in patients who experience repeated dislocation. First case report of a coronary stent to stabilize the lead in the coronary sinus was published in 2006. Several studies concluded that the lead stabilization by stenting based on coronary vein anatomy can effectively reduce the dislodgement rate from 10% to 1%. This is a case report recently published in the European Research Journal that is done in the New Delhi, India, where they used a drug-eluting stent to stabilize the lead. So in conclusion, stent implantation to stabilize the left ventricular lead position seems to be a useful and safe procedure in the treatment of patients with complicated coronary sinus anatomy, or lead instability due to the size discrepancy. And I'm thankful to my mentor, Professor Mir Nasaruddin sir, for his case, and my cath lab team of National Heart Foundation Hospital. Thank you all.